very much. So my name is Ravish, Sachar. Good afternoon. Pleasure and honor for me to be here. And PK, Peter, Pastor, thank you so much for inviting me. Great to see things coming back to normal again. My disclosures as they pertain to this talk, there's one important disclosure. The founder of a company that's developing some of the devices you're going to see, just keep that in mind. So good news first. Good news is that over the last 20 years or so, the outcomes with carotid artery stenting have steadily improved. As if you look back to the Sapphire Archer days to more recent studies, you find that 30-day death stroke MI rates have come down as patient selection technique devices have improved, so have outcomes. So that's the good news. The bad news is that if you look at the randomized trials comparing stenting to endarterectomy, and there's been several of them now, and large, not large in terms of coronary numbers or pharmaceutical numbers, but for carotid big trials, you find that overall the outcomes are the same. But if you look down to the subsets, you find that death is about the same, major stroke is the same, but minor stroke is almost always higher for stenting as compared to endarterectomy, and myocardial infarction is higher for endarterectomy as compared to stenting. So one thing to do is to say, okay, well, that's fine. That we just take that trade-off and overall the results are the same. But I don't think that's good enough. If you have a higher minor stroke, we should look for ways to reduce that risk of minor stroke and really make the procedure as safe as possible. So that is, I think, where we need to focus a lot of attention. What causes minor stroke and what causes stroke overall, so we can really make this as safe as possible. So if we want to do that, we really need to understand where the strokes are occurring, because that's the only way we'll be able to design technologies in order to reduce that risk of stroke. So broadly, there's three buckets. One is at the time of access, when you go up into the aortic arch, you manipulate your guide, catheters, sheets to get into the common carotid artery, some risk of plaque breaking off going up. And that's why you sometimes get contralateral strokes as well. Over time, as technique has improved, this number has come down. This 15 to 20% is probably 10 to 15 years old. Then there's a stenting procedure itself, where you go up with the pre-dilation balloon, the stent, and post-dilation. That really is where the majority of the risk occurs. And within that stenting portion, it's the post-dilation where you have a lot of risk, and I'll talk about that in just a moment. And then there's post-procedure. Once the patient is done with the procedure, out to discharge, out to 30 days, is there any risk of plaque protruding through the stents and going upstream and causing a problem? So those are the broad areas to keep in mind. And so the technologies I'll be talking about today kind of address those broad areas: improved embolic protection, mesh-covered stents, and radial access. Now the talk is transfemoral, but I'm going to talk about radial as well because it's endovascular, and it is a way to minimize the amount of manipulation of the aortic arch such that you can lower that risk of access-related strokes. So as I mentioned earlier, post-dilation during the carotid stenting procedure itself is particularly hazardous because you take a stent that's a self-expanding stent, push it up against a friable plaque with a large balloon, and as the balloon comes down, like a cheese grater, all that plaque comes through and goes upstream. And even if you have a distal filter, oftentimes that filter does not have full apposition. There's pores in there. Any particles smaller than pores can get through. And that really is where a lot of the minor stroke is coming from. So small microparticles, microembolic particles that are getting upstream and causing that high risk of minor stroke we always see in carotid stenting studies as compared to carotid endarterectomy. So the first technology I'm showing here is the Paladin balloon. This is a design for post-dilation. So you would do your procedure as you normally would, put the first filter up there, put your stent in there, but when you go for post-dilation, you use this balloon. And once your balloon is in position, that filter that you see distally is opened up right now, but comes in a closed position. And once you have your balloon in place, in your handle, you've got a knob, and as you turn the knob, the filter opens up, customized to the size of the individual patient's size of the vessel and the shape of the vessel. So it creates a full seal. And within it, there's 40 micron pores. So it really creates an efficient way of capturing all the microparticles that are released at the time of post-dilation, where again, there's a lot of risk. And once you're done with that, then you come down with the balloon, close the filter just by turning the knob the other way, and pull the whole thing out. So it really doesn't add any extra time to the procedure. Here's an example of a patient being done with this. You can see a stent and then the post-dilation balloon with it. And distally, there's that filter opened up with the markers. And at the end of it, you just close down the filter and pull it back out. The Paladin registry, 106 patients, again, not a huge registry, 30-day outcomes showing 1% 30-day death stroke MI. There was one stroke at day 12, and a patient did not take their DAPT regimen, but procedurally, there were no problems. So what was really interesting about this, though, is we did a histological analysis of all the debris that was captured in these filters, and it turns out 90% of the particles that were captured were less than 100 microns, between 30 and 100 microns. White blood cells, as an example, are 30 microns. So it's these small microparticles that were caught in this, but in a normal filter, which have 130 to 280 micron pores and really may not have good apposition, those particles are getting through and causing this risk of minor stroke that we've talked about. And this is corroborated by DW-MRI results. We did the same thing, looked at DW-MRI pre and post procedure with these patients undergoing filtration with this integrated filter. And we found that while normal incidence of DW-MRI lesions in patients undergoing carotid artery stenting with a single distal filter is in the 70 to 90% range, with this integrated filter, it was down to the 20% range, which is what you would expect with endarterectomy. And very importantly, the mean lesion volume, which is probably more important than the incidence, was also logarithmically lower because the number of particles and the size of particles that can get upstream is really, really small. So it really made a big difference. And this is important not just for reducing the risk of minor stroke, as I talked about, but more and more evidence points to a long-term risk of cognitive decline after carotid artery stenting if you have large amount of microembolization, microembolic debris getting up into the brain. If you look out to 5 years, there is a decline that happens the more the amount of debris that gets up. So it helps with that as well. So then this technology was then expanded as a next step from a balloon and a filter to a 3-in-1, a balloon, stent, and a filter, to put all of them together. It's a stent which has this novel asymmetrical hourglass design, but you already have a balloon underneath it that's already pre-positioned. So it's a self-expanding stent, but instead of going with a separate balloon, you already have a balloon underneath, so you can just do it all at the same time. And the same filter we talked about, making it a very easy one-step procedure. This was looked at in Europe in a study called the Performance 1 study, 67 patients enrolled in 9 centers, 0 strokes at 30 days, 0 strokes at 1 year at a correlated adjudicated study. This is now being tested in the US as part of an ID study called the Performance 2 study. 305 patients total. We're a little over halfway enrolled, and Mount Sinai, Peter, and PK are investigators in that as well. So there's been enrollments over here, and hopefully this will continue to enroll as we get to 305 patients, and we'll see what the results of that show. So moving on from that, talking about mesh-covered stents. So the idea of mesh-covered stents first came about when OCT was used to look at stents in the carotid artery after they had been deployed. And it turned out that in some number of patients, you could see plaque protruding out through the stent cells. And in this one particular study over here, it turned out that there was a higher incidence of plaque protrusion in open cell designs versus closed cell designs, leading to the thought that maybe there's protrusion of debris at the time of the procedure or maybe after the procedure as well, which may cause some procedural stroke, but also post-procedural stroke. So that idea came about. Interestingly, if you look at 2 large registries, the EXACT registry, which is many years old now, but was the closed cell stent, and the CAPTURE registry, which was Acculink and open cell stent, there was actually no difference in outcomes, both in symptomatic patients and asymptomatic patients prospectively. So that doesn't necessarily show that there's a difference between open cell and closed cell, but regardless, because of the interest in this risk of protrusion, mesh-covered stents were developed, again, with the hypothesis that the second layer would reduce the risk of a procedural plaque protrusion event or even a post-procedural event out to 30 days. And so 3 types of stents have been developed, which are mesh-covered. There's the C-Guard by Inspire MD that has 165 micron cell size because of PTFE mesh around the stent. There's a Terumo Road Saver, which has a 375 micron cell size, and the Gore Scaffold, which has a 500 micron cell size. And you can see these cell sizes are significantly smaller than what you see in normal or average closed cell designs and open cell designs. These have undergone various levels of evaluation. The C-Guard stent has undergone evaluation in several registries. I think the largest one is the Iron Guard registry, 200 patients, a 2.5% risk of stroke at 30 days. All of these were minor strokes. The Road Saver stent by Terumo underwent evaluation in the Clear Road registry, 100 patients, 1% risk at 30 days, so very, very good numbers. All of them are now undergoing evaluation or have already undergone evaluation in the US as part of an ID study as well. The Gore Scaffold study has already done enrolling. It had FDA approval, but Gore decided not to commercialize the device for business reasons. The Terumo Road Saver stent was evaluated in the Confidence study. That study is done enrolling. The data have been submitted to the FDA, waiting for the results from that. And the Inspire MD C-Guard device is being studied in the C-Guardian study, which is now starting to enroll in the US. So all of them undergoing some level of evaluation in the US. The Scaffold study, as I just mentioned, which has already done enrolling, has FDA approval, 30 outcomes in a per protocol analysis, 3% risk of death, stroke, or MI at 30 days, and a 1.1% risk of stroke at 30 days. So again, very good numbers. Moving on now to Radial Access. So as as I mentioned earlier, this is not transfemoral, but because of the concern about manipulation in the arch and potential risk of emboli occurring at that time, both ipsilateral and contralateral, leveraging the experience we have from the coronary side, a lot of interest has been there and growing experience levels and more publications in radial access for carotid artery stenting. So why radial artery for carotid artery stenting? Well, really the same reasons we choose radial access for coronary disease: decreased incidence of major entry site complications, decreased bleeding risk, which can lead to reduction in mortality, easier vascular access and hemostasis for obese patients, and obviously early ambulation as well, which is always beneficial. But it's especially helpful in patients with tough arch anatomy, steep arches, type 3, type 4 arches, such as what you see over here, or bovine left common carotid arteries coming off from the nominate artery, where there's really a straight path from the right radial into the left common carotid artery. It's not that hard a procedure. I know you're doing several of them over here. PK was telling me about one just a few minutes ago. You can use a reverse curve catheter like a Simmons 1 or a Simmons 2, form it in the ascending aorta, and then as you pull back, if it's facing one direction, it goes into the right common carotid artery. Facing the other direction, goes into the left common carotid artery. Once you have access in the common carotid artery, you can use your usual wire techniques, putting a wire into the external carotid artery and then exchanging out for a 5 or 6 French sheath to deliver your stent. Here's an example of a symptomatic 99% stenosis of the left internal carotid artery. You can see really high-grade stenosis in the symptomatic patient, access via the right radial artery. Once you have the Simmons 2 in place over here, a wire was advanced into the external carotid artery. Using that wire, a 5 French sheath was positioned in the left common carotid artery in the mid-segment. You can see a stent being deployed over here. Post-dilation over here is being performed with the Paladin balloon that I talked to you about earlier with the integrated protection. So you've got this 99% stenosis, very friable, soft plaque, high risk of embolization, mesh-covered stent, along with a balloon with an integrated embolic protection device with 40 micron pores, full protection in this particular patient with a radial approach, minimizing the risk of embolization both from the arch as well as risk of embolization at the time of the procedure during stenting as well as during post-dilation. There's been a lot of data now coming out on this. It's been reported from several centers. This is one retrospective registry in which we were involved along with another center in Europe of 382 patients in which there was a 91% success rate. The success rate from right radial to right carotid is almost 100%. Right radial to left carotid is a little bit less because if sometimes you don't have enough support in the arch, you can fail, but most of the time it works well. No bleeding complications and a 30-day stroke rate of 1.6%. So in summary, carotid artery stenting has steadily evolved over the last 2 decades, as you saw initially from the decreasing event rates at 30 days. Outcomes have been improving, and now expectation of a 30-day event rate of 1-2% or even less should be norm. Neurotherapies hold even more benefit or promise for benefit as we improve embolic protection, the degree of embolic protection, better stents, better access, better patient selection. But as always, aggressive medical treatment and risk factor modification and choosing the right patients is really important to get good outcomes. Thanks.
Anybody have any questions? So Ravish, I have a question. So we've seen that more than ischemia, the concern is embolization, which causes these strokes. So with the focus with the newer technologies, obviously to distal embolization protection, but also with the mesh-covered stents. So do we really need to focus on getting the stent apposed as much as we want, like what we see in coronaries? Or do we just want to modify the plaque to a more stable situation?
Yeah, that's a great question. So data out of the CAPTURE registry, that was about 3,500 patients when we did a subset analysis, this was more than a decade ago. We looked at independent predictors of stroke. And so, if somebody had a symptomatic status, that was an independent predictor of stroke. Interestingly, a 0% residual stenosis was an independent predictor of stroke, meaning that if you got too aggressive with your post-dilation and tried to get a perfect result like we do in coronaries, you actually have a high risk of embolization and high risk of stroke. So 20% residual is absolutely fine. You're trying to do exactly what you said, modifying the plaque so that the plaque does not have embolic potential anymore. Once your stent is in, after 30 days, you're going to have enough neointimal formation that the embolic risk of that lesion is now gone. If you try to push it up really hard, you're going to have a high risk of stroke at the time of the acute procedure with no real benefit long-term. So a little bit different thinking as compared to the coronaries.
Thank you. One last question is, since it's the updates on stenting, Do you think they're planning to use AI algorithms to predict some kind of plaques to see which one really needs to be stented and what stent would be favorable and what kind of lesion?
Yeah, that's a great question as well. So, the only way we really have that has been validated to decide who to treat, either with endarterectomy or with stenting, is degree of stenosis, right? But that's not really a great measure because you can have a high grade stenosis that's calcified, that's not going to cause a problem for a long time, or you can have a 50% stenosis that's got a vulnerable plaque and ulcerated that's is going to cause a problem. So, some type of imaging to be able to uh, uh, to to be able to see which one's going to cause a problem in the future would be great. We don't have that yet, or nothing that's been validated. There's been several ways that have been thought of, including AI, to look at that, but nothing that's been validated. I think if we can head in that direction, I think we'll be better off in terms of choosing the right patients to revascularize.
Thank you.